Hello, everyone. Today I have a case for you, and I will start. It's a very interesting case. It's a 78-year-old female comes to the complaint of weakness and weight loss. So the patient complained of hyperexia, inappetence, and asthenia in the last 2 months. She also had 7 kilograms of unintentional weight loss in the last 4 weeks, associated with some episodes of subjective fever.
Amazing. Amazing. Thank you, Dan. So it sounds like we have somebody who's been feeling fatigued and not quite well for 2 months, and they've had subjective fevers and almost a 20-pound weight loss in a month. What are you thinking?
Yeah, no, thank you so much, Amanda, for presenting this case. Maybe I'll just start kind of by examining, the limited data that we have already. So, weakness and weight loss, out of those two, I'm going to try and figure out which is going to be more of our diagnostic fulcrum to explore. Weakness, it can mean so many things to so many people. So, I think maybe once we get to the exam, that will be further clarified, and I won't spend a terrible amount of time on that right now. But the weight loss component, that's something that can be, very objectively documented in the chart, and the patient often has a pretty good sense of that. And when I think weight loss, that just kind of immediately puts me into this sort of bucket of constitutional symptoms. I think Robbie has like a great schema on this that, it's like calories in versus calories out. So is there some reason you can't get enough calories in to support your metabolic processes and therefore your weight? Or is there some sort of catabolic process? So your body is utilizing the sort of caloric intake that it is receiving and maybe going too far to the point where then you start to lose weight. So obviously, as an infectious disease physician, like this sort of triggers me in multiple ways of like, oh gosh, weight loss over several weeks with maybe subjective fevers, like that's already putting me in a bucket where I'm thinking like, gosh, chronic infection, subacute to chronic sort of inflammatory processes, or even a malignancy. I will say the last part of the weight loss schema of calories in versus calories out is also just kind of like dramatic end organ disease. So you can get like cardiac cachexia or something like that. Maybe if we just sort of entertain the weight loss plus fevers, that again is going to move me more to this like hyperinflammatory phenotype of infections, malignancies, sort of autoinflammatory disorders, and potentially sort of end organ endocrinopathies like hyperthyroidism or thyrotoxicosis. In the infection standpoint, Amanda, is this patient from Brazil as well then? Yeah, in the infection standpoint, then we have this, we're filtered by the time component. Like this is unlikely to be rip-roaring sepsis if it's been going on for 4 weeks. It's unlikely to be sort of an acute bacterial infection. So I'm thinking more sort of the things that could, persist and develop and evolve over a several week time period without sort of leading the patient to medical care at this point already. And that's going to be something like atypical infections. Obviously, TB is a concern in parts of the world where that's perhaps more common than the United States, although we see a terrible amount of TB in San Francisco. Non-tuberculous mycobacterial infections, endemic fungal infections like histoblastococcus. And then, you could also get things like subacute bacterial endocarditis that I think would be a major cause of something like this. Viral infections would be less likely for that time period, but, sort of associated syndromes with certain viral infections like viral associated malignancies could be a possibility as well. So I would say like, I'm intrigued by this presentation already. There's not a terrible amount of fulcrums to go on. So I think this will be a great opportunity to hear more about, this patient, what is their contextual sort of background, what medical problems have they experienced in the past, and what exposures have they experienced apart from residence in Brazil. And then it will be kind of a hunt for any sort of thing on the physical exam, labs, or radiology that then we could hyper focus in on and say like, is it a chest nodule plus fevers and weight loss, which will have a much narrower differential diagnosis. Robbie, I've had like 4 cups of coffee already. I feel like I'm going 100 miles an hour. Anything you would add to that, or any
No,
other? Like
I have
that?
nothing to add. I'm right there with you. I drank way too much coffee today, and I'm probably getting a little bit of an adrenaline jolt just watching you poetically dissect this case, especially with my reference points being most dominantly in your distant past. It's so cool to see your diagnostic process skyrocket since your last time here at time on VMR. It's really cool to see. I'm doing the mental exercise of trying to explain to our team here why you're so excited. And I think that it's almost in reverse order of what we have on the board, and maybe in the reverse order of what the patient has, because Dan is teaching us that you should worry because this patient has weight loss and the other stuff is non-specific. But if you analyze that weight loss situation in isolation, when somebody says, "Hey doc, I've lost weight," you actually, maybe I'd say 70% of the time, you want to high five them and fist bump them and give them a hug and congratulate them. So the question here is, even though the weight loss is the most important feature, it's actually the combination of these two symptoms that allows us to go down the diagnostic tree that Dan is outlining. It's because when people come in with isolated weight loss without any company, it usually is of no diagnostic importance. Usually when patients say, "I've lost weight," and you're waiting for something else and nothing else follows, it's usually the kind of weight loss to celebrate. So I think here, while the weight loss gives us diagnostic momentum, I think the accompanying symptoms exclude the possibility that you need to high five the patient and congratulate them for the weight loss. So it really is the combination of the two that is taking us down the world, though the weight loss is much heavier than the accompanying symptoms. All right, Amanda, tell us more, please.
So in the past medical history, and the patient recently diagnosed with anemia under investigation. She has hypertension, diabetes, Alzheimer's disease, and a previous episode of ischemic stroke in June 2021. Lipidemia, non-allergy in the med. She Ramipril, metformin, pioglitazone, memantine, aspirin, and atorvastatin. In the family history, she father died due to a heart attack, and her mother died by unknown cause. In the social history, denies use of alcohol and is a non-smoker.
Sorry, Amanda, where is this patient currently residing? Are they in like a congregate setting, like a nursing facility or something like that?
No,
She living with her family then?
yes, she lives with an uncle.
Gotcha. Robbie, should I take a stab? Do you want to take a stab? How should we go? Okay. Gotcha. Well, I think this is important and certainly interesting, sort of color added to the case. Just sort of like systematically looking at the past medical history, the thing that perhaps, I guess the two things that perhaps stand out the most to me are, this anemia under investigation. I don't know the degree of anemia, but certainly that could either be signal or noise, depending on how dramatic it is. So I'm interested to see what her labs look like and maybe hear a little bit more about the investigations that it's undergone. But certainly anemia could be something that's like a paraphenomenon of another inflammatory process, or potentially a bone marrow process, or the list is quite long with anemia, but we see it commonly, and it may or may not catch my eye, depending on how severe it is. And then just also the sort of Alzheimer's and perhaps like vascular dementia picture as well, depending on how severe that is, that might limit the sort of exposures that this patient has. I was interested in whether or not this patient is in like a congregate living facility, just from the sort of infectious risk that might entail. But it may argue that she's probably spending more time at home with family than engaging in sort of intriguing infectious disease exposures out in the community. It also raises the possibility of a variety of infections that we see in older folks. Like, does she have a urinary catheter, and does she have sort of swallowing dysfunction and causing her to frequently aspirate, or is she bedbound, and does she potentially have like a sacral decubitus ulcer? So those would be considerations that I would then sort of investigate further on exam. I will say that the diabetes, that could be a slightly immunocompromising condition. But, the spectrum of diabetes is pretty broad. Maybe her A1C is pretty minimal, or it could be at 14 that's going to predispose her to reactivation of a previously acquired infection or something like that. I'm talking infections. I'm trying not to be the prototypical infectious disease doctor because we see a lot of malignancies and everything else too, by virtue of her age and, maybe mapping on with some, sort of spurious anemia. Certainly a malignancy is going to be common in this age group as well. In terms of other stuff, I think that those are kind of the majority. I'm not seeing anything that changes our framework already. I'm still, on the top of my steno pad here, I'm saying weight loss and fevers. So nothing is dramatically shifted the focus at this point. And I think that we'll probably get a greater sense, again, trying to localize this sort of inflammatory process to some organ system. So whether there's something very prominent on exam or labs or radiology, I think that will then be like the pivot point in this case.
Completely agree. I have absolutely nothing to add, but to really marvel at Sammy's ability to keep up with the medication list. That was so impressive, Sammy. Really nice job. And I don't know if Mukund knows this, but his Google name is Anonymous Tiger, which I think is absolutely perfect. Thank you, Mukund, for keeping up with this with the teaching points. All right, Amanda, tell us.
So the vital sign, her blood pressure is 130/80. Respiratory rate is 20. Heart rate is 82. SAT is 96% on room air. Temperature is 38 degrees Celsius in gen. Well, appearing, confused, pale mucosis, pulmonary and abdominal are both normally, and she has a regular heart rhythm, diastolic murmur in the apical area, 2 out of 6 intensity. So extremities and skin are normal.
Rob, you want me to go again, or you want to take the lead? Okay. Well, our suspicions at this point have been confirmed with the temperature elevation. So no longer is it in the realm of like subjective fevers. This is clearly an inflammatory syndrome at this point. And now, as I kind of highlighted before, the hunt will be on for anything that we can map it onto. And we're going to aim for increasing specificity. So, as an infectious disease consultant, often I have the data entirely in front of me by the time I'm called on the case. So I may get called when there is a, cavitary lung lesion, and I can kind of retrospectively go back. So I'm going to try and do it in reverse and be, Robbie in the emergency room of trying to really see where, trying to guess where the signal might be. The things that really stand out at this point are the hypoxia on room air. 90 is not great. It still may be, a red herring in that case, but it's something that may point me more towards the lungs as a focus of disease. And then obviously the murmur, diastolic murmurs are classically something that we're not going to be terribly happy just kind of pushing up by the wayside compared to the systolic murmurs, which could be either benign or pathologic. So the diastolic murmur in the apical area, I'm no cardiologist, but that kind of sounds like mitral valve to me. And mitral valve is one of the more frequently involved valves for bacterial endocarditis. Other things that I, as an infectious disease physician, would look for on exam is like really paying attention to like their fingers, their fingernails. Do they have any splinter hemorrhages, any signs of like Osler's nodes or Janeway lesions? You can look under the sort of palpebra to see if there's any sign of embolic foci there. And then, really digging into a neurologic exam. If we are entertaining endocarditis in this patient, is this something that they're then going to have like a new neurologic deficit that they may not have had before? Other things that I frequently pay attention to is any scars over sort of articulation. So do they have like a joint replacement, a hip replacement that may serve as a focus or a metastatic site for a bacteremia perhaps? And then I also look at any sort of intravascular catheters. That's gonna be something that's super important for us to highlight. Doesn't seem like it's a big issue in this case, but do they have an implanted chest wall port from a prior cancer? Do they have a PICC line, a dialysis line, or something like that we'd want to pick up? So at this point in the case, I'm increasingly intrigued. I'm not ready to put my nickel down on anything. I'm thinking this murmur is something I'd further evaluate, but our entry point into really thinking about endocarditis is going to be microbiologic data. So even though this patient has a fever right now, of utmost priority is going to be obtaining blood cultures before giving antibiotics. This is one of those things where you want to pause before sort of jumping to empiric treatment, because on the back end that makes our life so much easier if we have clean blood cultures as well. I'd also, at this point be thinking, gosh, I want to look more at the lungs. Is there some sort of focus of infection in the lungs? And then, as just from a numbers game, elderly person living in Brazil, I think somebody said in the chat, is there a TB history? Was this patient ever treated for TB, had a TB contact or something like that? And getting a chest x-ray would be a great initial step. So to summarize, intrigued, the murmur, I think, is something we should further evaluate, but still maintaining a broad differential diagnosis at this point for a subacute febrile syndrome in an elderly patient.
Amazing, absolutely amazing. I couldn't agree with you. I think the murmur is real focus, and I think that that if I play around a little bit with that with the crowd, I think we can, as a group, try to come up with any clarity on what this murmur means, as Dan is using it as a powerful pivot point. So as a group, what does a diastolic murmur in the apical area translate to you all? Type it in the chat. What do you think it might represent on echocardiography? A diastolic murmur in the apical area. All right, Mukund. So Mukund is mentioning the possibility of mitral regurg, and then Madison is saying mitral stenosis. And I think that that's the key part about oh, no worries at all. Yes, we agree that a diastolic murmur either represents mitral stenosis or aortic insufficiency. And I think the fact that it's located in the apical area is one clue that it's mitral stenosis. The other clue that the vast majority of chronic aortic insufficiency comes with a significantly wide pulse pressure. So the lack of a wide pulse pressure in the face of a diastolic murmur is even more support that this is mitral stenosis. There's one thing, and then thank you, Ravi. I should be more clear. There are other reasons that you should think of aortic insufficiency in the apical areas because of the Austin-Flint murmur that Ravi is teaching us about. So I think it's the combination of it being in the diastolic area plus the normal pulse pressure makes aortic insufficiency a little bit less likely. But there's one other clue in the history that suggests that this is mitral stenosis. Thoughts on what that clue in the history might be? All right, what do y'all think? Give you 10 seconds. What in the history supports the notion that this is mitral stenosis? Yes, Lucas, that she's in an endemic area in Brazil. So the combination of mitral stenosis is most commonly the result of rheumatic heart disease, which is a very common issue in Brazil. It also may represent the result of radiation, which this patient does not have exposure to. Can you all think of another cause of acquired mitral stenosis? Actually, I'll just say it for the sake of time. So the valve might be the cause of mitral stenosis, in which case it's rheumatic over radiation, the two R's. But the patient may have an acquired cause of mitral stenosis, not because of the valve, but because of something growing on the valve, namely an atrial myxoma. So here, I think that you have to step back and say the valve is not co-opting well. Is it rheumatic fever or is it a myxoma? And then you ask yourself, is there any evidence that the valve has already caused problems? And the recent evidence of that stroke comes to mind. So the question is, has this patient had a long-standing valve issue and had valvular thrombosis or valve causing AFib causing thrombosis? So I think, Dan, you're absolutely right. The most morbid hypothesis is the following. The patient has some sort of valvular issue, likely mitral stenosis, but that murmur that we hear doesn't account for the fever. It's just that she has a vulnerable valve and that vulnerable valve got infected in some way, shape, or form, or we're wrong that it's mitral and she has aortic insufficiency, and that's the primary manifestation of endocarditis. The hidden teaching there is that endocarditis usually causes regurgitant murmurs. It is true that if the valve vegetation is so big, it can cause obstructive murmurs, but usually regurg would be the more likely mechanism. But I'm holding on to one other hypothesis, which is this patient does not have an infectious cause of endovascular disease, that this may all be an atrial myxoma causing fevers, which is notorious to do. The hole in that hypothesis is most patients with atrial myxomas who have a febrile illness are usually in their middle age. She's a little bit old for that. So I think what we can, to summarize the teaching on the valve, a diastolic murmur in the apical area is often hard to tease out between three possibilities: mitral stenosis, AI with the Austin Flint murmur, or, as Madison pointed out, a VSD. What are your clues to tease them out? AI will almost always, especially chronic, come with a wide pulse pressure. A VSD, if you listen enough, should be a continuous sound, not the sound exclusive in diastole, but because of the difference in the diastolic pressures is higher than the difference in systolic pressures, you might hear it more prominently in diastole. So probably mitral disease, infection, or tumor, probably infection, especially since it would be a very nice way to welcome Dan back to VMR. But I'll give the mic back to Amanda.
Maybe I'll just interject one thing real quick. Just in terms of the rheumatic fever question, and thank you for so much for the review on murmurs, Robbie. That was great. I'm like binary murmur fever. I got to get an echo, blood cultures. In terms of rheumatic fever, I think again this age sort of puts this patient so far beyond. So if rheumatic mitral disease, it's going to be more of a consequence than sort of an active inflammatory condition right now. So I wouldn't necessarily think that the fever at this point is going to represent rheumatic fever, which tends to happen much, much earlier in age. And actually, I was doing a board review question on this earlier today. It's like, if you have a bout of rheumatic fever, your risk of having subsequent bouts of rheumatic fever is elevated. And you actually do like monthly, IM, penicillin injections to prevent that. And that can even extend out for, months to years, depending on your age and the number of times you've had rheumatic fever. But rheumatic fever isn't something that's likely to currently be occurring in this 78-year-old, but we are, very, very reasonably could be seeing the sequela of prior rheumatic fever that she had when she was in her youth. Group A strep is one of my favorites. I'm happy to chat ad nauseum about group A strep.
So in the left, the patient has hemoglobin 6.6, red cells 3, hematocrit 21%, WBC 18,000 with 7% neutrophil and 8% basophil. 200,000 of platelets. Kidney and liver function are normally. CRP is 70, and I have a venous pH. The pH is 7.5. PCO2 is 27. Bicarbonate is 21.1. Lactate is 5.2. I will stop here.
Excellent. Well, Amanda, thank you for all of this data. This case just keeps getting more and more interesting. Maybe just starting with the hematology component, the elevated white count. I think of that, kind of going back to basics. Is this a primary process like a leukemia, or is it something that's reactive? In the context of this fever, and a likely inflammatory syndrome, my guess is that it's going to be reactive, although that's something that we're going to be able to get more sort of in-depth knowledge of with the smear. The basophils, that seems weird. That's not totally normal, but if this has been going on for a while and the marrow is stressed, I imagine it could be a manifestation of a reactive leukocytosis, although that catches my eye, and I'd probably ask for a smear after this. The hemoglobin being low, it sounds like this was something that is pre-existing, unclear if she was at the mid 6s before, or this is something that's sort of coming down in the context of her acute illness. You have to kind of go back to your ABCs and ask, is she bleeding? Is there, some hemolysis going on that you might be able to see or get a sense for, again, with the smear and some other sort of ancillary tests like the LFTs. And then looking at the platelets, sometimes we'll see the platelets super high with, an inflammatory condition, but it can be, normal in an infection as well. It not being super low may argue against some weirder infections like leptospirosis or something that you might otherwise consider. The CRP, it, I think, confirms what we thought before. It's elevated, it's an inflammatory syndrome. And then the VBG with lactate, that lactate's kind of higher than I was going to think for something like this. And lactate, you think type A, is it a impaired oxygen delivery, or is it going to be a type B where it's, maybe not related to tissue ischemia or hypoxia? But that certainly is going to elevate my overall concern for how this patient's doing. This is certainly something that's on the higher side. Oftentimes, I imagine this patient will probably get a liter of fluids as they come through the ER, and then you can kind of evaluate if it's a hyperperfusion mediated thing or not based on the response there. Certain cancers, I know folks might be thinking like Warburg effect, if that was, Warburg effect of like an elevated lactate in the setting of a malignancy. That could be, sort of delineated further by cross-sectional imaging. I'm intrigued by the pH stuff. It kind of seems like maybe she's got a respiratory alkalosis. I wonder if that's driven by her hypoxia. But, maybe I'll kind of leave it there for that. And just summarize that, the lab sort of confirmed where we were going before, is this seems like an inflammatory syndrome. I'd probably want to get inflammatory syndrome plus minus on the background of an abnormal bone marrow. So I'd want to get a smear to kind of see further. But really at this point, I think my needle will shift dramatically based on imaging and culture data. Just maybe briefly to speak to, if this patient does have endocarditis, like, could this be a compatible CBC? Elevated white count, sure. 18 is pretty high, but we could see that. I feel like it would be hard for her to have a white count of 18 for 4 weeks, but maybe this is creeping up and she's kind of reached a tipping point. The hemoglobin being low can certainly happen, right? Like you get this inflammatory syndrome that then sort of creates like, anemia of chronic disease phenotype. So that is low, but maybe if she started at like 7.5 from like having a somewhat diseased bone marrow, maybe like early MDS or something, it could drip down to the 6s. I think that's probably, maybe I'll stop there just in the interest of time and toss it over to Robbie, but saying like, I think all bets are still on. I don't see anything that dramatically, etch-a-sketch it, shakes the etch-a-sketch of our thinking so far. And I'm going to hang on for dear life for the chest X-ray and microbiology.
Yeah, there's a big wrench in the fork. Like, I think that this train is screaming endocarditis, and then the basophilia would be unexplained. And so the question is, how much do I need to explain the basophilia? And the caveat to make there is you may not need to explain it, or it may be explained by a different unrelated disease process. And I think basophilia in an older adult basically means CML or a basophilic version of AML. There are some diseases that can cause a reactive basophilia, including iron deficiency, but this degree of basophilia should push you to examine the bone marrow. So I think what's happened here is like, there's so much support for endocarditis. You have fever and valve issues, and now you have a neutrophilia, which you can't argue with, but the basophilia is interesting. And I think the caution there is it may not be explained. It may be explained by an underlying vulnerability to endocarditis, or there may be a hidden clue that it's not endocarditis at all. Amanda, enlighten us, please.
I have some exams. The urine analysis without change, AKG without change, and we have an X-ray just present with a cardiomegaly. And I have 2 more exams that give us the diagnosis. Can I say? Okay. So we did an echocardiography. So with aortic valve vegetation and a blood culture positive for enterococcal SP with the final diagnosis infective endocarditis.
What do you think, Dr. Minter?
I love Enterococcus. It's my jam. That's a favorite bacteria, gram-positive cocci. So maybe just like one, I know we're over time. So 1 minute teaching on Enterococcus. Overall, when you're seeing endocarditis, what most of you will probably see is Staph aureus. Staph aureus is a bad actor, and all rules are meant to be broken, but Staph aureus will tend to present relatively acutely. So 4 weeks, you won't really see with Staph aureus endocarditis, with some caveats. Enterococcus and streptococcal species are something that you definitely can see present with this kind of more subacute presentation. Madison's saying E. faecalis in the chart. I kind of think of it as a seesaw. There's two big species of Enterococcus, E. faecalis and E. faecium. E. faecalis is the one that causes more endocarditis, but less vanc resistant. It's almost never vanc resistant, versus faecium is less endocarditis and almost, much more frequently vanc resistant, so VRE. So, when you see a patient with enterococcal endocarditis, it's one of those things that, sort of puts you, it's like a gateway diagnosis. It makes you think like, do they have like a, underlying GI pathology or GU pathology? And it's certainly one of the things that Robbie probably sees a lot at the VA in our older population there that may have a lot of genitourinary problems. There's some thought about like, should we start screening these patients for colon cancer, as you might do with strep bovis or strep galolyticus, but it's not currently standard of practice. It's a fascinating bacteria, a single positive blood culture, that then sort of vanishes. That's unlikely to be endocarditis. So my suspicion for endocarditis from a microbiologic standpoint is going to be much higher with prolonged symptoms if we don't know where it came from, and then if there's 3 or more positive cultures off antibiotics. So maybe I'll stop there. I love Enterococcus. It's fascinating. It's a kind of pain in the butt to treat sometimes, but it's certainly one of those sneaky ones you want to think about for longer presentations of endocarditis like this.
Dan, I love your ability to teach us complex things like the nuances of enteritis, but also just how you simply walked us through the journey. You're like weight loss, inflammation, what kinds of chronic inflammation, and then use the murmur to help you zero in on endocarditis. And I think that the one growth point for me was to ask the hard question of, well, how does the anemia? I'm not here. Anyone out there? Yes.
Y'all heard it. Robbie's not here right now.
No, I meant like not clinically. Not on the job yet for another 25 minutes. Well, I was going to say like the anemia, like how could the anemia be connected here? And I think it might be interesting to see if it was microcytic and to hone in on the GI source as a potential cause. And I'm curious to study the big gap in my knowledge. Amanda, do you have any advice or learning about the basophilia in this case? Tell us, please.
So it's not clear to us too, and the patient was encaminhada for dermatology for investigation because it's a black space to us too. But the patient, she was treated with penicillin and progressed well. After some weeks in the hospital, today we sent her home, and she was so happy and so good. And about the basophil, it's under investigation.
Amazing. You know what humbles you? If you had anchored and said, I have to explain the basophils, you would probably miss the diagnosis. So it's so cool to be flexible in these domains. Amazing. Thank you, Amanda. All right, Mukund, take us home, please.
Sure. Ton of learning for this one. We started with a discussion of weight loss, thinking about calories in versus calories out, and have sorted this into inflammatory causes such as cancer, infection, versus non-inflammatory causes, including intake problems, access problems, malabsorption, so on and so forth. And in this person with weight loss and fevers, we decided to focus on an inflammatory and particularly an infectious cause. We talked about kinds of infections that this person might be experiencing. With a 2-month time course, we focused in on atypical infections, endemic mycoses, TB, and bacterial endocarditis of the subacute nature. We also focused in on a couple of infections that may be more likely in the elderly, including due to indwelling catheters, sacral decubitus ulcer infections, and so on and so forth. But things got really interesting when we did our physical exam and discovered this diastolic murmur, 2 out of 6 in the apical area. Of course, immediately endocarditis comes into play as a significant suspicion. And so we talked about the approach to endocarditis from the physical exam, looking at the hands, the fingers, the eyes, and looking for any other devices that may be plugged into this person, as well as obtaining blood cultures before giving antibiotics for the best specificity. We went through a really educational, for me, breakdown of apical diastolic murmurs, including mitral stenosis, aortic insufficiency or regurgitation, and a ventricular septal defect. David brought up a really interesting point about endocarditis primarily causing regurgitant murmurs. And so this was something that was on my mind, especially since mitral stenosis has 2 more common etiologies, of which rheumatic fever and atrial myxoma are really up there. In the end, it did turn out to be aortic insufficiency mediated endocarditis due to enterococcus, which is a gram-positive cocci. Enterococcus and streptococcus, we learned, present subacutely, while Staph aureus presents more acutely, and so we'd be unlikely to see this 2-month time course. And finally, we learned about the 2 most common species of enterococcus, fecalis and faecium, of which the latter is vancomycin resistant, but a more uncommon cause of endocarditis. There's also some information up there about lactic acidosis, type A versus type B, which I find educational for myself. And a little discussion about basophilia, although it doesn't seem like we really understand the reason this person presented with basophilia in this case. Will be a really interesting way for me to educate myself after this session is over. Thank you, everybody.
Absolutely amazing, Mukund. Thank you, Amanda, for a brilliant case. Dan, for such a treat to have you back and to nerd out with you, internal medicine and otherwise. This was not planned, but I'm glad that Amanda had a nice ID treat buried in there for you right at the end.
I'm glad that the basophilia didn't throw me.
Yeah, I know, right?
Oh my gosh, shit.
Bye, y'all.
Yeah, thanks, everybody.